Hello everybody and welcome back to Maternity Leave Lectures. This lecture is about, as I've told you before, my favorite disease, tuberculosis. And just like I said before, this is my favorite disease because it's interesting and complicated, not for people to have. Tuberculosis is caused by bacterium called Mycobacterium tuberculosis. That bacteria is acid fast, so it's got mycolic acid in its cell wall, and it is a bacillus shape. One of the things about the bacterium that's interesting is the fact that it's a strict aerobe. So it lives in places where it can get lots of oxygen, because it requires oxygen in order to grow. So that's why one of the things that we're going to find out here is that tuberculosis infects the lungs, because of course that's in the body, that's one of the places where the most oxygen is present. Mycobacterium tuberculosis is very slow growing, and in some cases can take up to 6 weeks for colonies to appear if a culture is made. As I mentioned, these are acid fast, so they have mycolic acid in their cell wall, but they also have waxes, so mycolic acid and other waxes are present in the cell wall, and that makes them rather sticky. So they stick together when grown. If you look at them under the microscope, that's what is called cord factor, because they have all these lipids and waxes in the cell wall that makes them clump. It also works to make them resistant to drying and resistant to disinfectants. So Mycobacterium tuberculosis can live on surfaces for a long time, and it takes rather strong disinfectants to kill them. This is what Mycobacterium tuberculosis looks like when grown in colonies, and this is what it looks like under the microscope when an acid fast stain is done. And we call this structure, the fact that these bacilli are sticking together, we call that kind of the dragon of TB. Because they have sort of a dragony look to them. Tuberculosis, or TB, can come in two forms: primary and secondary. Primary TB is a contagious disease that happens right after initial infection. So primary TB would be if you were exposed to TB and then several days to a couple weeks later you developed disease from it, and you would be contagious. In most cases with primary TB, the bacteria infects the lungs. So what happens is then the immune system can wall off the TB bacteria in the lungs, creating lesions. These lesions are what can be identified, and one of the ways that TB can be diagnosed. This can actually be dangerous. It sounds, the fact that your immune system walls off the TB in the lungs sounds like it's a good thing, but it can also be a dangerous thing, especially if those lesions become necrotic. And again, necrotic means that this tissue is dying. So nobody really wants dead tissue growing in their lungs. Another thing that can happen is these lesions can become calcified, and you can see that for years to decades later on chest x-rays. Now, secondary tuberculosis is what we call reactivation tuberculosis. What I'm going to mention later on is that TB, once you're initially infected, sometimes you can go into a latent period where you have latent TB infection. That means that you have the bacteria present in your body, but it is not actively growing and reproducing. It's not actively causing disease. Your body has it at least somewhat under control, so it remains dormant. Now, this bacteria, when it is in its latent state, can remain dormant for weeks to months, years, decades. But after an unknown period of time, something triggers the tuberculosis to become active again. And then we get secondary tuberculosis, reactivated tuberculosis. It can become reactivated when your immunity starts to wane for whatever reason, because you're getting older. If you develop another infection like HIV infection, if you have cancer and you're going through chemotherapy, that can reduce your immune system. And what we see in foreign countries especially is poor nutrition can trigger TB to reactivate. As I mentioned before, most of the time TB affects the lungs. So we call that pulmonary tuberculosis. Signs and symptoms for pulmonary tuberculosis, of course, include violent coughing. The coughing can bring up green and bloody sputum. Okay, it includes a low-grade fever, anorexia, which means you don't really want to eat, so you end up losing weight, fatigue, night sweats, and chest pain. However, there are some times, and this is rare, but it does happen, there are some times that the bacteria migrate out of your lungs and build up an infection in other parts of your body. This is called extrapulmonary TB. And for the most part, the organs that become involved with extrapulmonary TB would be lymph nodes around the lungs. The intestines can become involved, the kidneys, long bones, so like the femur, for example, even the genital tract. Now, we have seen cases of TB in the brain and meninges before, and these two, although rare, are extremely serious and can be deadly. A patient of ours in North Dakota had what was called a brain tuberculoma, which was a lesion that contained TB in her brain and had to be removed in order for her to survive. TB meningitis, so TB that infects the meninges, that lining around the brain, lining around the spinal cord, that can be dangerous and deadly if it's not kept under control. You see this mostly in very young children. TB is transmitted through fine droplets of respiratory mucus suspended in the air. So it is contact with respiratory fluids, and it is passed through the air. So you can be in the same room with somebody and contract TB. You don't have to have close personal skin-to-skin contact or contact from blood to blood. Transmission is through the air. Now, that being said, TB, when it is expelled out through coughing, forms large droplets that have a tendency to be heavy and fall out of the air. So it's easiest to catch TB when those droplets become a fine mist and can spray further in the room. TB is also spread easier, or it's more likely to get TB when you are in close contact for long periods of time with somebody with TB. So it's not like the flu, where you can just be in the same airplane with somebody coughing and catch the flu from them. With TB, it's more likely to be transmitted through prolonged contact with somebody who's actively coughing. Now, I mentioned before that TB can live on surfaces for a long time because of that waxy cell wall. Well, just touching TB on a surface and then touching a mucous membrane is not necessarily going to transmit it. TB is not infectious unless it's aerosolized. It has to enter your lungs in order to cause disease. TB is diagnosed a few different ways. Just having the infection, so that means having the bacteria present in your body, can be tested through, the most common route is through what we call the Mantoux skin test. This takes something called purified protein derivative, and it's basically an antigen of TB. It is injected just under the layer of the skin, and then a couple of days later it's checked to see if there's any immune reaction to that antigen. And that would be hardness or raised area around that injection. A more expensive but more accurate way to test for infection with TB is through a test called an IGRA, which is an interferon gamma assay. This is a blood test to see if your T cells can react to TB. And again, it challenges them with antigen to see if they react. These tests, again, they only diagnose infection, so that just means that you've been exposed to TB, you have the bacterium present in your body, but it doesn't tell us anything about if you're contagious or not. So remember, it can be latent, it can be in a dormant state. Now the test that, this is the skin test, the Mantoux skin test. Just under the skin, some of that antigen, that PPD, is injected. Then a couple days later, 2 to 3 days later, it's checked to see if the area is hardened and raised. Okay, the ways that we can diagnose actual disease, active disease, and therefore contagiousness, is by directly staining, doing an acid-fast stain of a sputum sample. Sputum is not just the mucus that comes out of your nose, it's not the saliva that comes out of your mouth. Sputum is the fluid that is coughed up from deep within your lungs. In the case of TB, that sputum will contain mycobacterium, and it will also have distinct appearance to it if there's active disease present. So you can do an acid-fast stain directly of the sputum sample. Another way to diagnose TB, and usually is done in conjunction with the acid-fast staining, is a chest x-ray and CT scan to look for abnormalities. And there are distinct abnormalities that doctors look for with TB. You can also do a culture of the sputum, and then you can also do PCR methods, which PCR stands for polymerase chain reaction. Looks for specific DNA sequences that are linked up to TB. A positive result in any one of these tests indicates that you are contagious. Now here's an example, a couple examples of chest x-rays of people with TB. This case on the left is a milder case. You can see that there is congestion in the lungs. That's where the bacteria would be growing. This case on the right here, this is a much worse case, because you can see cloudiness all over the lungs, but especially where these arrows are pointing, there's this hollowed out area. This is what we call a chest cavity. That means that the TB walled itself off, or the immune system walled off the TB, and that lesion became necrotic. It started to die away, the tissue started to die away, and that actually ate a hole in this person's lung. And that can be a really dangerous complication, because a hole that opens up in the lung can cause the lung to collapse. The good news for TB is that it is curable. Unlike HIV that we talked about before, TB can be completely cured. And it's cured through antibiotic treatment. For people with active TB, that means contagious active disease, treatment lasts between 6 and 9 months, can go up to 12 months depending on the situation. But typically the first 2 months of that are a 4-drug cocktail is used. The 4 drugs that are typically used are rifampin, isoniazid, ethambutol, and pyrazinamide. After those 2 months are over, then we go down to 2 drugs, which are rifampin and isoniazid. Rifampin and isoniazid are considered first-line treatments for TB. Latent tuberculosis, that treatment, the typical treatment that we use, lasts about 9 months, and it is a single drug treatment with isoniazid. And that usually does the trick of getting rid of the bacteria so that it does not reactivate later. Shorter course treatments are becoming more popular that combine isoniazid and rifampin. Now, it's important that people are treated for TB because untreated disease has a mortality rate of 60%. So that means if you have TB and you do not get any treatment for it, you have a 60% chance of dying from TB. If you decide to go through treatment to cure TB, it's extremely important, especially in this case, that you comply with the entire course of medication. Because as we've seen with other diseases before, like MRSA, non-compliance with treatment or not taking the full course of antibiotics can lead to drug resistance. And in the case of TB, this drug resistance is extremely serious. There are already several drug-resistant strains already circulating, and we classify them into two groups. There's the multi-drug resistant TB. That's resistant to at least isoniazid and rifampin. Those are those two drugs I mentioned that were the first line of defense against TB. Unfortunately, there's also extensively drug-resistant TB, or XDR. These are resistant to isoniazid and rifampin, just like the others, but they're also resistant to any fluoroquinolone and at least one second-line injectable drug. So that means not only is it resistant to the first-line drugs, but it is at least partially resistant to some of the second-line drugs, which means that it is incredibly hard to treat and cure XDR TB. There is currently a vaccine available against TB, and this is called the BCG vaccine, Bacillus of Calmette-Guerin. We do not use it in the United States, but the countries that do use it have it because they have a higher incidence, they have more TB than we do. And it's extremely dangerous for young children to get TB. So they'll use this vaccine just to vaccinate really young children to help prevent them from getting meningitis. But the reason why the U.S. doesn't use this vaccine is because it's extremely poor efficacy. 50, maybe 60% of people that get the vaccine are protected, and it's usually only for a short period of time. It also can complicate the interpretation of the Mantoux skin test, because people that have received this vaccine will react to the antigen, and it can give them a false positive on that test. Now, I mentioned that there are some countries that use this BCG vaccine, and that's because in other countries there is an extremely large number of people that have been exposed to TB at some point and have that latent infection. So it's estimated that 1/3 of the entire world's population has at least latent TB infection. That's 1/3 of the world. In 2012, there were 8.6 million new cases of active TB diagnosed globally. Just in the United States, thankfully the United States TB is at relatively low levels compared to the rest of the world. In 2013, 3 out of every 100,000 people in the United States were diagnosed with active TB. In 2011, there were 536 deaths related to TB in the United States. So even though we have very few new cases and we have treatments available, there are still people dying from this disease. Most cases of TB that get diagnosed in the United States right now are among people that were born outside of the United States. So we think that most of the cases that come up are because people were infected in their home country and then with latent TB infection come to the United States, and at some point, because of whatever reason, that disease becomes reactivated. Now, this is just showing you how when we go from the early 90s to right now, the proportion of people getting TB cases is shifting, or has shifted, from U.S. born people making up the largest proportion of TB cases to people born in other countries, foreign-borns, making up the majority of TB cases. So you can see that here U.S. born is in the blue, whereas foreign-born is in the aqua. There are areas of the world, as we mentioned before, a third of the population of the world we think are infected with TB. Well, you can compare these areas of the world that have the most TB to the areas of the world that are also the poorest. We definitely can see a link between TB and poverty. Now this again is because we think that because there's so much latent infection going on, the real danger is in reactivation. And reactivation occurs when the immune system is suppressed. So things that are linked to poverty and also immune suppression are inadequate nutrition, poor access to medical care, and lung damage from other things like working in industrial settings, working around chemicals that can damage the lungs. This map here is showing you the places in the world where TB is in the highest numbers. Unfortunately, there are some areas of the world here in Africa and parts of Russia that we do not get any data for. So that's why they're white. That doesn't mean that they don't have TB. You can see from the small data that is here that around Russia there's actually quite a bit of TB. Okay, those are some of the highest numbers. Africa also provides some of the highest numbers of TB, but unfortunately, because reporting from those countries is so scattered, we don't have a lot of information on it at this point. TB is what we consider a really ancient disease because basically as long as we have records of human beings existing, we have records of TB being along with us. We've even found TB in mummies from the Stone Age, mummies from ancient Egypt and Peru. So people going back that far had to deal with TB and were dying from TB. It's come up in history quite a bit. It used to be called Captain of the Men of Death. It's been called the White Plague, and it's been called consumption throughout time. Back in 1882, Robert Koch, who came up with his postulates, he's also the one that came up with the first link between a bacterium and an infectious disease. He discovered that Mycobacterium tuberculosis is the causative agent of TB. So he first discovered anthrax as the causative, Bacillus anthracis as the causative agent of anthrax, and then he moved on to TB after that. Not until 1946 did we have an antibiotic that was effective against TB. That's streptomycin. It reduced the rates of TB significantly into the 50s, but then, of course, as soon as streptomycin started to be used, it was used just by itself, a single drug treatment. So as soon as that started to happen, TB that was resistant to streptomycin emerged. TB is such an important part of our history that there are quite a few very famous people that either suffered from and recovered or died from TB. So these are people that you might have heard of before. Elizabeth Barrett Browning, she's a poet, died of TB in 1861. Henry David Thoreau, a very famous writer who died of TB in 1862. Dmitry Mendeleev, he's the creator of the first periodic table of elements. Now he didn't die of TB, but he did have TB at one point in his life. If you've ever watched the movie Gone with the Wind, then you know who Scarlett O'Hara is. And the actress who played Scarlett O'Hara in that movie, Vivian Lee, she died of TB or complications due to TB in 1967. Even Eleanor Roosevelt, the former First Lady of the U.S., she had TB and it reactivated in her bone marrow. She died from complications due to that in 1962. If you need more information on TB, these are great resources for you, especially information about TB history at that last link down there. Remember, if you have any questions, go to the discussion board and leave your questions there. Thank you very much.